Mark asked me to present just a little bit on the guidelines for cholesterol management. And I realize this is a thrombosis forum, but the fact is with the majority of cardiovascular thromboses, of course, are initiated by lipid injury to an arterial wall. And if you did a particularly good job of managing lipids, there are some studies that would say that with appropriate lifestyle, smoking, and diet management just by itself, you could prevent 80% of cardiovascular mortality. Then maybe Mark Chan would be out of a job and having a conference on what to do with all your free time instead of thrombosis. I'll just emphasize this is data from Singapore, that cardiovascular disease is, of course, a major contributor to mortality, with 30% of all deaths recorded in Singapore from cardiovascular disease. So not only is it a major cause of mortality, almost more importantly is something called a DALY. So if you're not in the field, you may not know what that means. It's a disability adjusted life year. So these are the life years normalized by essentially how bad you feel or how dysfunctional you're made by a disease. And when you start counting that way, then cardiovascular diseases dominate essentially a ranked impact on society. And this is, again, data from our own Ministry of Health. To give you a sense of what that means, so each one of these disability adjustments has a number associated with it. So heart failure, which is a common endpoint of thrombosis in cardiovascular disease, you have about a 0.173 score for that. If you're in an intensive care unit, your score is much higher. Your disability adjusted life year is 0.6555. You spend a year in an intensive care unit. If you lose both your limbs, but you get replacement, it's 0.1. If you get a prosthesis, it's 0.1, and if without, it's 0.4. The interesting thing I found in this analysis was heart failure has almost to the thousandth place exactly the same impact on your life as a year-long chronic inflammation of your testes. Just in case you need to put it in scale of exactly how bad cardiovascular disease is. The reason the World Health Organization quantifies this is this justifies all the measles, mumps, rubella vaccinations. So everybody's always stretching for a new way to frame their disease in the common field, so I guess that's my contribution here. Cholesterol lowering improves cardiovascular outcomes. If you count up the billions of dollars that it took to make this graph, it's almost unbelievable. I mean, generally speaking, clinical trials have gone from the right side of the graph to the left, improving cholesterol and operating on lower baseline cholesterol population stepwise. This is secondary prevention. For those of you not familiar, is if you've had a heart attack, how do you prevent the next one? Primary prevention is in populations that haven't had a heart attack at all, and you're trying to reduce their risk. So as we've gotten more and more modern trials, they've come down in here with a recent Improve It, which is yet another statin-based trial, which pressed the limits all the way into an LDL level of average LDL of 50. And no matter what trial you have, as you go to lower cholesterol, you improve outcomes. There's probably one of the better established facts in clinical medicine, in the history of clinical medicine. So I'm supposed to just walk through in a practical way the two guidelines from the European Atherosclerosis Society, European Society of Cardiology, and the American Heart Association, American College of Cardiology. The talent pool in both of these guidelines committees is unbelievable. I mean, I know some people who are on both, and they are some of the smartest, most dedicated people out there. Each group took a little different approach. EAS, ESC, really took all evidence in the creation of their guidelines, whereas AHA-ACC said, we only want randomized, controlled, the highest quality data to make our advice on. It's a subtlety, but it plays out in a very interesting way. So this is the ESC-EAS, and so they take a little bit more of a societal view, where they start with population effects. And so if you just make a population richer, their cardiovascular outcomes improve quite dramatically, actually. And as you go up this triangle, it's more and more of a patient-specific outcome. Things that are here, like education in young people to eat healthy, clinical interventions is really where the guidelines as a doctor-to-patient relationship focus. So cutting to brass tacks, at the end of the day, if we're clinically intervening, this really is the guideline here, this single figure. On this axis, you have your cholesterol, LDL-C, and on this axis, you have the risk of the patient. And the goal of these guidelines is to take an underlying risk and match a treatment decision based on a causative element of cardiovascular outcomes, which is low-density lipoprotein. So the way in which that risk is assessed is critical. So in the ESC guidelines, there are two types of risk assessment. One of them is just qualitative, so low to very high risk, and we'll talk briefly about that. The other one is calculated. So either one of these can determine your treatment outcome. So low to high risk, as you read through the guidelines, you'll find this table here. So this is things like known coronary vascular disease, obviously high risk, prior history of a heart attack, peripheral arterial disease is a risk equivalent. Documented disease on imaging, a documented high probability TIA, diabetes with target organ damage. And this is a little different than the other guidelines because here in the ESC, high-risk diabetes is a bit differentiated from very high-risk diabetes is differentiated from high-risk diabetes. And the high-risk group would be diabetes without end organ damage, also moderate chronic kidney disease. And then as you go to lower risk groups, that's where you use the calculator. So this is what the calculator looks, and probably the best thing to do, in all honesty, is to print this out, find a color printer, and put it in your office. So all of this is women versus men, blood pressure here, age, and whether they smoke or don't smoke. So the primary cardiovascular risk factors. And the important thing to note here is that the blood pressure part is what the blood pressure was before you got treatment. So everybody comes in your clinic, they're already on antihypertensive. So unfortunately, this information is lost to a lot of us who need to initiate this treatment. Generally speaking, the pre and post treatment blood pressure doesn't affect these numbers by more than a 3% margin. So you usually don't get major changes, but in a perfect world, you use the pre-treatment blood pressure. So interestingly, when you read through these guidelines, and I have to admit, I was stumped on this for just a little bit. There are two charts here. So there's this chart, and then there's a second chart. And they look exactly the same. And in order to figure out what the difference is, you have to read down here in the smallest of font. So each one of these charts is meant for a different population. And as technology develops and you can recharacterize and recalibrate populations, this chart may change. So what does that mean specifically? So these are European guidelines. So the low risk chart is for these countries. The high risk chart is for these countries. And so what is the cut point? The cut point is about 450 cardiovascular deaths per 100,000 people as an incidence. So I looked into it a little bit more because they don't have any Asian countries in these guidelines. So where would we fall on these charts? By the way, I think this clicker may be out of battery because it's not going forward anymore. Can you manually advance forward, please? I think there we are. So the death rate per 100,000 in Asia is this. So all of these are underneath that 450 per 100,000 mark. With Philippines and Indonesia having the highest incidence of death from cardiovascular disease. China at 300, India 306, so very, very similar. As you go down to Singapore, things get just a little bit better at 108, and as a reference, USA is 132. But one thing that I didn't fully appreciate, go forward, or maybe give me another clicker. So look at this. So if you're in Turkmenistan, it's 712. That's unbelievable. I mean, so if you think about the cardiovascular risk in India, which I would think of relatively higher. I think of Indonesia as a high smoking prevalence country, right? Where you have a high risk of cardiovascular outcomes, or Philippines. These Eastern European and Russian states, 700, 600, 500, they're almost double of what we think of as rough coronary artery disease in Asia. So the epidemiology in these areas is really extreme. I didn't really appreciate that until I went into the World Health Organization statistics. And then the lowest, as some of you may know, is Japan, which is 82. So imagine that. The difference between Japan, 82, and Turkmenistan is almost tenfold for those countries' differences. It's unbelievable. So factors that modify the underlying score risks beyond those adjustments, and this is important when you're really talking one-to-one with patients, things like that social element is exactly the difference in many of those countries. Physical inactivity, psychosocial stress, and then some of these other, in particular for those of you who treat the HIV population, they are at extremely high risk for coronary vascular events as well. So all of those are kind of exceptions to the rules and aren't necessarily included in those standard risk factors. So the workflow, first see if they have a qualitative categorical risk. If they're in this category, i.e. they don't, you then use this chart, which in Asia you'll use the low risk chart. And by the way, it really underscores the need for epidemiologists in Asia to come up with region-specific risk matrices for our own clinics. And then once you have that calculation, you take this, say 5% here. This is a 5% total mortality risk over the next 10 years. And this puts you in your risk stratification. Remember, this is total cholesterol here. This is LDL here. So that's how you decide your treatment target in clinical action. So in essence, that is the ESC guidelines. We can go into a little bit more detail, which lipids to assess. So LDL-C is the primary lipid analysis and has by far the best data. The other lipid analyses largely are there for a more subtle assessment of risk of that patient. There are also some familial conditions which happen with some of the lipid subclasses. But at the end of the day, especially if you're in allied healthcare or a generalist, LDL is the primary treatment target. I can save some people some trouble. So everybody here who works in a clinic has had somebody who shows up to the clinic, they forgot to do their labs because they weren't fasting. So the question is, do you send them all the way back home for another appointment and cause all of that trouble because they weren't fasting and take their labs? It is okay for them to take the labs and go ahead and check them at that clinic. And right, if everybody does that, we just save probably 100,000 man-hours of time to poor family members. We have to bring that person back. Now, the fasting lipids are not quite as accurate, and the recommendation is that we do remain fasting, but there is a substantial evidence base to say that that fasting level is still good enough for clinical decision making. And I'm guilty of that myself, saying, no, they didn't do the fasting labs, come back and do labs next time. But in reality, it's not absolutely necessary. So the agent choice, you may have guessed, is indeed a statin with a class 1 recommendation. The next tier is bile acids and ezetimibe, which are reuptake inhibitors. If that's not reached, then obviously a combination treatment. And what Dr. Tai Shang will talk about is a new class of medications called PCSK9. When you're selecting the statin, this is a beautiful graph from the ESC guidelines showing the dosage and lipid lowering of each drug. And one thing that I think of rosuvastatin as by far the most potent statin as it is, with Rasuva 20 milligrams being really a very high statin dose. But you know what? Atorvastatin 40 comes awfully close in these type of studies in terms of LDL lowering. And really, if you want the absolute tippy top of lipid lowering, Rasuva 40 will do it. Rasuva 40 obviously is a very high dose of statin. But you know, Atorva 40 comes awfully close. And for those of you who want to go to Atorva 80, it essentially equals a rosuvastatin. And of course, the classic statins in here. So The evidence base for using statins for that is the biggest evidence base in the world. So I can't even talk about individual trials because to talk about one, I would have to talk about 26. In a meta-analysis of 177,000 people, in general, you can say that as you reduce per 1 millimole per liter, you're going to reduce cardiovascular events over a 10-year period by about 20%-ish. And you will also reduce stroke rate. And that is one of the best supported medical evidence claims that you can find. So the other agents, so how about this? If I just hold this up like this, maybe you can forward it. That'll be our signal. Bile acid sequestrants are a very old drug, but you know what? They're actually seeing a bit of a resurgence in interest for the following reason. That as opposed to statins, when you initiate someone on a bile acid sequestrant, you can also improve their diabetic profile. So you may see more development in the bile acid realm, and there's right now a lot of industrial interest in improving bile acid relevant therapies because of that dual effect. And of course, ezetimibe is a popular medicine. Ezetimibe, when added to simvastatin, brought us down to this line here. Okay, so way to the left for the population that was studied there, they still were able to power the study and show a mortality benefit. The PCSK9 inhibitors are almost unbelievable on the same axis. So when this graph was made, they didn't even make the axis far enough to get the average LDL for the PCSK9 inhibitors. It was 30. So imagine that. Dr. Tai Shang will talk about that in greater detail. But just imagine if Brown and Goldstein had discovered PCSK9 as sort of the most relevant cholesterol-mediating protein, and you had gone from the first trials here to PCSK9 inhibitors as the first step. You could have avoided all of that development in the meantime. They're unbelievable, potent drugs, and even cast against the billions of dollars of development here, they still show an improvement and grossly support the cholesterol hypothesis. So, and then lastly, are lifestyle changes, not to be minimized. We won't go through all of this, but the ESC guidelines really have just a beautiful little chart in terms of the magnitude of the effect of the intervention, the level of evidence that backs it up for lifestyle changes. And some of the things that as I read through this again, I found it interesting. Red yeast has a relatively high ranking in this. And of course, dietary trans fat is at the top of the list, and indeed saturated fat as well. But yeah, so red yeast is actually 2 stars for magnitude of effect, level of evidence A, which is something that in my clinic I certainly maybe could pay more attention to. So the ACC-AHA guidelines are subtly different from the ESC guidelines. And we'll go through these quickly. I think in Asia, it tends to be the European guidelines that are followed more traditionally. But AHA took a little different approach. They took clinical questions, and then they assessed randomized controlled trials to assess the recommendation for risk treatment. AHA would say the lack of RCT evidence to support titration of drug therapy to specific LDL goals and or non-HDL goals is a driving force. So what they mean by that is that there's no magic one-size-fits-all LDL. Because if you had a heart attack and a low LDL, you had a heart attack at that LDL, right? So it's always internally relevant. So their argument would be, no matter what your LDL, you just had a heart attack of a prevalent disease that's ultimately likely to kill you. You should be on a statin by virtue of that risk, not necessarily because of the absolute value of your cholesterol. And that's the subtle difference between the 2 guidelines. So the AHA gives you a nice flow chart as you go through their guidelines, and it basically starts. The fact is, both of these guidelines, if you look at if you put one population on one and the other population on another, the number needed to treat by virtue of a difference in the guidelines in order to see one difference in mortality is extremely large, right? So I mean, the effect size of one guideline versus the other is actually very small. So we're talking about the fringes, the very fringes of cardiovascular outcomes in terms of the difference of choice of guidelines. Now the cost, that's a different question. These guidelines start at the same place. If you have atherosclerotic disease, then boom, you're on a high intensity statin. But that term, I'm not sure intensity has been used in any guidelines up to this approach. So it almost sounds like some kind of a headache. What does that mean? It's the dose relative to the dose range of that drug. So there's a specific chart for high intensity, moderate intensity, and low intensity statins. So high intensity, obviously for patients with known atherosclerotic cardiovascular disease. Then you look at the cholesterol after that. If you have a very high cholesterol, so LDL greater than 4.9, again, high intensity. Diabetes, so here's where probably the biggest divergence in the guidelines happens. Diabetes with a low, if I have somebody with diabetes and their LDL is 70, I'm awfully happy. That would be somebody with a 1.8 LDL. That's extremely good. Here, if your LDL is 72, you still get a statin with diabetes. And that's a risk-based decision rather than an LDL-based decision. Then as you go into so basically all diabetics above age 40 are on a statin in this flow chart. In the primary prevention mode, if you don't have diabetes and middling LDL, then you go down this pathway where you specifically estimate a 10-year atherosclerotic cardiovascular disease risk. If it's greater than 7.5%, then again, you undergo clinician-patient discussion, but a statin is indicated. So how do you calculate that risk? It's different than ESC. This is something called a pooled cohort risk calculator. And this is largely from US populations. So again, this isn't as relevant to Asia. And one of its criticisms is that although it includes population subsets such as African Americans, it does not account for group population differences in the way that low and high risk ESC calculator does. So I think that's one reason in why the European guidelines are used more in Asia. There is a wonderful online tool for the risk assessment as well. And then going on, so initiating statin therapy, there's clearly a nice flow chart for that as well. But the most important thing is that initiating moderate intensity statin therapy, you also counsel on lifestyle habits. Again, the difference with the ACC-AHA is you're monitoring LDL not to treat to a target, but to monitor the compliance of the patient. So that's very interesting. So the corollary of that is, the AHA doesn't say this, but if you're absolutely confident or let's say you have another compliance measure of the patient, like a Bluetooth medicine dispenser or something like this, do you still monitor the LDL then? They would say, well, if you're using it for medicine response, for compliance purposes, you wouldn't. They don't go that far. So, and we'll see with the addition of the PCSK9 inhibitors whether their guidelines change. So again, they give specific flowcharts for monitoring the adherence to the drug. If you're intolerant, then you can change to a different treatment, similar to ESC. So to finish up, a lot of people had this kind of feeling about the new guidelines. Should we be putting it in the water? And believe it or not, in the most recent guidelines, they literally say they have to be explicit to say it is not appropriate to default prescribe it to everyone in your clinic, regardless of the reason. They actually go that far to actually explicitly say that to prevent just complete saturation of every patient with a statin medication. Asia, this is so relevant, the diabetes difference. So these are the circles for the number of patients with diagnosed diabetes from World Health Organization. So if you're going to say that all those 40-year-old plus people on diabetes are going to be taking a statin, the epidemiology of statin administration itself becomes massive, specifically in this area. Their take-home principles are not, from the AHA is not to focus on LDL and use medicines proven to reduce risks, which again, in their opinion, is certainly statins, which is well supported. So just two more thoughts. Special classes. So remember, there's no medical evidence to see a benefit of statin treatment in hemodialysis patients. And I know as a physician myself, it's awfully hard to look at a hemodialysis patient that you already know is going to die from a heart attack and not prescribe them a statin by virtue of medical evidence and statistics. But the fact is there are essentially 2 reasonably powered trials which did not show any benefit in dialysis patients. Heart failure is a little bit more of a gray area, but again, especially as you get to more severe heart failure 2 and 3, their ability to benefit from statins as a class also is highly blunted. And then lastly, I'll put in a plug for familial hypercholesterolemia. So FH, some of you may think of as relatively, why do I need to diagnose FH when I'm measuring the cholesterol and treating the cholesterol, and the cholesterol is the problem? The reason FH is important to know about is it's really your opportunity to save a life of a young person who may or may not be in your clinic at that moment. So FH is familial, it's genetic. There are clear criteria, both from the Dutch consortium and Simon Broom, for diagnosing FH. There's simple criteria, and probably the easiest thing to remember is any LDL above, certainly above 8.5, is essentially certain to be familial hypercholesterolemia. Even in the ranges as you go up from 4.9 to 8.4, the probability is increasing with this score as you add it into the rest of the matrix. Simon Broom, likewise. And I think in this region, recognizing more of the FH population can do a lot of good in terms of not just that patient who will be for sure treated, but their family members. And then lastly, can I advance? So just a bit of a reminder of how to treat familial hypercholesterolemia. Class 1 evidence to start with a statin and shoot for, it's a class 1 recommendation I wanted to point out for what's called cascade screening. Cascade screening is taking that index patient and screening their family members for familial hypercholesterolemia. So we'll just summarize this way. Both guidelines are extremely high quality. And the ESC guidelines assess the risk of the patient, adjust the LDL to that level that addresses that risk. AHA is a little different in that you prescribe a statin medication to dose demonstrated to lower CV risk in terms of its intensity, but you monitor lipids to ensure compliance. But one thing that's true for both sets of regulations or guidances is no level of LDL-C below which benefit ceases or harm occurs has been identified. So there's never a problem to driving that LDL as low as you can. And that really is the setup for Prof. Ishang's presentation on PCSK9 inhibitors, which have opened up an entire new realm of LDL targets for treatment. So hopefully I gave you just a little bit of a feel for both the AHA and European guidelines and an overview for one of the most effective known measures of preventing thrombosis in the first place. All right, so I guess that's it. If anybody has any questions, you're welcome to ask, or you can find me after the talk as well, of course. All right.